Welcome to In the ED Now, a podcast to make you an excellent physical therapist in the emergency department. I'm Dr. Rebecca Griffith, the ED DPT. Today's episode is amazing. We're going to talk to Dr. Nika Jacobson, who is a physical therapist in the emergency department in Vail, Colorado. And so her practice primarily centers around working with athletes coming down the ski mountain with injuries of all kinds. So she's going to talk to you about acute management of those types of injuries, how she best streamlines their care, and what you can do to be successful in this type of setting. I hope you don't miss it. Thanks for being in the ED Now. We appreciate you listening. Hi, welcome back to the show. We're in the ED Now. Welcome, Dr. Nika Jacobson. We're so happy to have you.
Thank you for having me. I'm excited to be here.
Well, tell us a little bit about yourself. You and I work together some at University of Colorado Hospital, which is amazing. But today we're not talking about that. We're talking about how you've used your EDPT background to work in a slightly different setting. So tell us just about your background and how you got into the ED in the first place.
Yeah, so I think my ED interest started when I was a student. I know you came and talked to my PT class, and I just remember thinking the ED was a great combination of a lot of things that I love and care about. Being able to see people same day for an acute complaint and being able to address that in the moment, as well as start the referral process and get people to the next best place. And just being able to utilize more of the primary care skill set side of PT, which is, I know, evolving and up and coming, and I wanted to be a part of that. So I started my career in acute care, working on the floor, of course, during the pandemic. So got a lot of experience with more like cardiopulm and just being able to meet people where they're at that day. And then started in the ED at university. And since then, I've been able to be in a seasonal role in Vail, Colorado, working in their ED. Yes. Yes. So now I'm part of Howard Head Sports Medicine, which is affiliated with Vail Health. And this season, I've had the opportunity to work in their emergency room full time, helping all of our skiers and snowboarders with orthopedic injuries and everyone else that walks through the door. So including our local community in the valley here, and then anyone that's visiting who just happens to have something else going on other than an orthopedic injury.
That's amazing. So I think the first question I think people are going to have for you is, you're a new grad working in the ED?
No. So I started working, I guess I graduated in December 2019. And so I've been working for over 3 years now.
So I'm going to argue with you that that's still kind of a new grad, that early career professional. So that like 0 to 5 years is, I would say it's still probably unusual for somebody to be starting their career in the emergency department.
Yeah, I would agree. It's definitely a unique skill set that I've had to quickly learn and develop. And of course, still learning and developing.
Yeah.
Especially
that's a question I get all the time, though, is how do I start my career in the ED? So based on your experience, because you're doing it.
Yeah.
What would you tell people who are like, God, I want to do that. I don't want to wait until I've been a PT for 10 years. I want to do it now. What would you tell people to do?
Talk to PTs that are in the ED. I mean, I know that you were my person that I talked to, and I know that we developed a relationship early on, and pretty much any opportunity I had to shadow, observe, work in a place that has a program, or even if they only take consults, just kind of get your foot in the door. I think that's how I got to where I am. And then just getting as much exposure as possible to the ED, because it is a very intimidating place. At least for me, it was, especially as a newer grad, when you're still developing your clinical reasoning and being able to communicate effectively with other providers and establish trust with them. I think that skill set is so critical for the emergency room. And so there are a lot of ways you can work on those skills before you even get into the ED. But I think just putting yourself out there and talking to the people that are doing it day in and day out is how you got to get there.
I love that. And for any
Mhm.
students who are listening, like Nika was so proactive even as a student and wanted to come to the emergency department and shadow and was like committed to that. So if you're like, gosh, I'm a student and I really want to do this, like you need to start being proactive, reach out to people, make those connections. And
Mhm.
ironically, the day that Nika came to shadow me, we had 0 patients. So we were just kind of chilling in the ED, but it was
Yeah.
still kind of a really good way for her to show that she was interested and committed and she was willing to give her time to come and
Mhm.
just be in that environment. So kudos to
Yeah.
you for like finding that
Thanks.
path and blazing a trail, because it is a question a lot of students have. How do I get into the emergency department, especially if I can't get a clinical? So that's great advice.
Yeah,
So
and also oh, sorry, I just
no, go
wanna
ahead,
interject.
please.
Also, like, anything that you can do to help establish that skill set prior, like, I know I was in an outpatient neuro setting, like, halfway through PT school, and I think that really helped with my, like, vestibular, experience, and that's
Hmm.
something that you have to be pretty strong in for the emergency room, so anything that will help facilitate that later on in your career, I just take full advantage of that.
And I would argue that there's no bad clinical to prepare you for the ED.
No, there
that
really
that
isn't.
like, because I have students say like, where should I go on my clinical? Anywhere,
Mhm. Yep,
because you need to know all the things.
yep,
So like just being mindful of what you're learning in each setting. So I think that's also
yeah,
great advice. I think outpatient's definitely helpful because you get that like turnover,
yeah,
that quick turnover time, which can be hard for students, I think.
yeah, yeah,
All
I
right,
agree.
so like let's get back on topic here because I've totally
Yeah.
gotten us distracted. Um, Working in the emergency department where I work is an
Mhm.
urban academic medical
Yeah,
center. It's got 100 beds. We're mostly seeing people who are having health literacy issues,
yeah.
complex medical care problems, older adults with falls, things like that. And so some people are like, I don't know that that's for me. But
Mhm.
what you're doing is totally different from that. So you're in Ski Town, USA,
Yep.
Vail, Colorado. Please come visit and ski in Vail. It's
Yes.
amazing. And you're seeing athletes and high level performers. You're seeing people from all over the world. So kind of
Yeah,
compare and contrast a little bit for me, since you've been in both of those settings, the differences between that academic medical center and that like literally tourist town medical center.
yeah, so Vail Health is, it's an interesting hospital because a lot of it was founded in its orthopedics. So, the Simon Hawkins Clinic, now Steadman Philippon, they've really created this mecca for orthopedic care. So people already are used to traveling to Vail to get their orthopedic care.
Hmm.
And then, of course, we have the resort. So from about November through April, we have this influx of tourists. And when the tourists aren't here, we have a pretty big local community. And so Vail Health is the main hospital for all of Eagle County. So that's all the way east from Vail, going west all the way towards Gypsum. And we're kind of, our barriers are Vail Pass and Glenwood Canyon. And so there's a lot that we are a little bit in a bubble from,
Hmm.
because of those geographic barriers. So I would say that we sometimes, you kind of have to function a little bit like an island when things come in. But of course, we have the resources to get people out. So, Flight for Life when we're able to fly. And then, of course, our paramedics are able to drive when the weather is not great. Um,
That's a real issue for people. I think sometimes
yeah.
people don't understand that. They're like, oh, it's great. I'm going to go skiing. There's so much snow.
Yeah.
But you and I both know that that highway
Hmm.
can close at any second, even if it's
Yeah.
May. Sometimes it's June.
Exactly.
And so having those resources to get people out, I think, is critical,
Right.
even though
Yeah.
sometimes they can't.
Exactly. And so our emergency room, we have attendings, we have nursing, and we have EMTs. So um, at university, you have other mid-level providers like PAs and NPs, and then of course it's an academic center, so you have residents and kind of like this big, like
Lots of
not linear, yeah,
resources.
just
Lots
lots
of
of people,
resources.
yeah,
Yeah.
yeah. And here it's much more limited, and so um, we also don't have every consult service. So frequently where the doctors are getting on the phone, talking to other hospitals in Denver, trying, if there's anything that we need that we don't have. So like we don't have neurology. And as a PT, that's someone that I'm really used to working with. And so I will say that there are times where you have to figure out, is this situation in which we need to call neurology today, or can we refer to outpatient? And can this person get outside of Eagle County to see a neurologist? So sometimes it's just a matter of figuring out level of acuity and what you need in that moment for that patient. But that being said, with the resort, predominantly with physical therapy, we're seeing lots of orthopedic injuries. So I learned this week that we had over 700 PT consults just at the Vail emergency room. We also have a Beaver Creek emergency room, which is just 10 or 15 minutes down the road. And we had, over 700 consults. And I think I personally saw over 400 of them. And so high volume, lots of knee injuries. So we're thinking MCLs, ACLs, meniscal tears, tibial plateau fractures.
Oh, yeah.
And then, of course, the ones that I don't necessarily see, but we see later on in inpatient or outpatient are femur fractures, fib fractures. And of course, there's always ankle and foot involved as well. We also have a lot of AC joint separations from our snowboarders who are falling, and a lot of clavicle injuries as well. And then calf strains, that's actually the third most common ski injury.
Interesting.
Yep. So just doing a lot of education around how to manage those types of injuries, and compression fractures. I will say that's also up there between cervical and lumbar spine, sometimes thoracic spine, but that's usually more in our older geriatric population. And so working with the doctors on bracing, figuring out what type of follow-up is needed, because most spine docs that we're calling aren't here, depending on the acuity. So I would say that's most of who I got to see. We do have a lot of closed head injuries because trees do not move.
They don't.
Trees always win.
No.
Yeah. So also doing a lot of education and trying to get people into concussion PTs as well. Because it was every day, multiple times a day, that we had people who were there for concussion, and just ruling out any type of other brain bleed or more serious
So probably a lot of imaging happening there.
Oh my gosh, yes. So have become really good friends with all the imaging techs, lots of x-rays, CT, and sometimes MRI, just depending on how serious of a soft tissue injury. There's several people that blow out their whole knee. There's, just a lot of, I will say a lot of injuries that I have never seen before. I got to, even if I wasn't directly involved in their care, being able to understand how the other providers were managing it and who else is involved in their care.
Well, geez. So I think all of that makes a lot of sense with like the boot situation.
Yes.
So like where the body has to bend and torque given the like stability of the boots. So that makes sense to me. How many of these patients do you feel like really should be going to like an urgent care versus an emergency care situation?
Yeah, I think that's a great question. I think that there are, pretty much anyone that's weight bearing, I usually associate with more of an urgent care status, but it's also tricky because we have people who hurt their knee the day before and came back the next day, and turns out they had a tibial plateau fracture and they were, doing their best. Yeah. And so it's hard because I know, I do the blog post for the EDDPT, and I just went over Ottawa knee rules, and there's times where it's like, man, but I've seen people walk on their fracture and it's not great. And so how do you, everyone pretty much gets an x-ray. We're here as long as it's clinically indicated, and the attendings are always involved in that. But I will say that there are a lot of people that could go to urgent care instead, but we actually Vail Health has created a whole streamlined process of um, when ski patrol brings you down the mountain, you either will be in an ambulance because medically you need one, or you go into a ski transporter van, which is a complimentary service of the hospital. And so if you dislocate your shoulder, if you hurt your knee, there are ski transporters that will. They're very fancy vans, very cool gurney beds where you don't even have to do any lifting. It's all automated and remote controlled. And then you basically get brought into the emergency room. So really part of it is, even though maybe some people could go to urgent care, a lot of Vail Health is actually built to absorb all
to
of
kind
these.
of serve that patient population
Exactly.
explicitly. So I guess my next question is, are you still skiing? Because I feel like if I was doing this all day, every day, there's no way that I would still be going skiing. I would be like, no, hard pass. No thanks.
Yeah. Yeah. There are definitely days that are really hard, I will say. I still ski. Actually tore my ACL skiing 4 years ago. So part of it is feeling like I have that experience of what it's like that day to hurt your knee, and just really have to come to terms with what the next year of your life is going to look like. And also trying to figure out what do I do now? Like, who do I need to see? What needs to happen? Like, am I
Yeah.
getting surgery? And just dealing with a lot of that ambiguity and uncertainty.
Mhm.
But I do still ski because part of it is I always joke that I'm going to go to the base of the mountain and just watch everyone walk away from the resort, because I know that I'm seeing a very small percentage of people that
Yes.
aren't walking away.
Yes.
And I think a lot of it is just reminding yourself that it's, not everyone hurts their knee or has an injury after skiing.
Or
And
hugs the
also,
tree.
right, exactly. And also it has changed the way I ski. So ski a little slower, I make different decisions. And also just knowing what risks are out there and kind of accepting that risk, because sometimes things happen.
Yeah, hats off to you, because I feel like I would probably be scared to walk in the parking lot after that. But I
Yeah.
definitely feel like I want to make my kids wear a helmet when they go outside to play in the driveway.
Yeah.
So, I don't think working in the emergency room has done me any favors from that perspective. Also, I just
No.
personally I hate snow, so you're never going to catch me
Mhm.
up in Vail working in the emergency department. So I'm going to leave
Yeah.
that to experts like you who actually know about skiing and enjoy that.
Yeah.
So if somebody's like, hey, this sounds like an amazing job, like I could move to Vail for a season, I could do like
Mhm.
sports injuries, which I love, and I
Yeah.
can ski on my days off.
Yeah.
Is that really like how it is?
Yeah, I would say I've felt very spoiled this season. My schedule was actually 10:30 to 7. So just based on the fact that the resort opens around 8:30, and then most of the winter it closes at 3:30, but because of the later sun, it's been 4. I started 10:30, so I would go ski for about an hour and a half before work on whichever days I want, because I live here, so it's easy to get there. And then work the rest of the day. And I was Monday through Friday, so I didn't get I didn't have any days off during the week, which I know some people really like up here because the weekends are
Mhm.
really busy. But honestly, just having that hour in the morning when the snow is the freshest and you get to just ski and then go to work, um, it was it was I'm I'm very grateful for that experience. And then also depending on the snow conditions depends on what type of patients you expect to see that day.
Okay, tell
So
us about that.
yeah, so softer snow, more snow, you expect more soft tissue injuries, just because a lot of people will get their skis stuck in the snow or crossed, or sometimes they hit a mogul funny and then their body goes one way, their knee goes the other way. So you expect more ACL tears that day.
Mm.
Versus if there's no new snow, it's really cold or icy, you probably would expect more fractures. So, usually I'd walk in and say, okay, I think today is going to be an ACL day. Or, oh, I think today is going to be more of like clavicle, shoulder dislocation, boot top fracture kind of day. So, but then some days kind of fool you. So you never really know what's going to happen still. But I always felt better knowing what type of snow was on the ground, because that would help me prepare for the day.
That makes a lot of sense. So
Hmm.
at least it's a little bit more predictable than your traditional emergency department, where you kind of have some sense of everything's going to be lower extremity today or orthopedic. What other kinds of diagnoses are you seeing in the ED up in Vale?
Yeah. So I do home safety evaluations, especially for pelvic um, pelvic fractures.
Mm,
Mostly just trying to figure out if their pain is controlled well enough to ambulate and go home safely. Part of it too is also just because we have so many tourists, can they travel? So, they're going home the next day. Can they
yeah.
tolerate sitting on a plane? Can they tolerate the drive to Denver? Um, how are they going to make that happen? So part of it's also just discharge planning.
Yes.
Um, I do see people who come in with vertigo. So, it happens everywhere, kind of regardless of what ED you're in.
Hmm.
And being able to help facilitate any type of like consult recommendations or referral processes for after, especially since we have a really well established brain and balance program at Howard Head. So, trying to get people in as soon as possible for that referral process.
Mm.
Um, and then, yeah, I think that's mostly it. I just think that sometimes people will come in and if they're not moving well, the attendings knew that they could talk to me about it, and or if other random muscle strains like hamstring strains, adductor strains, things like that. So I would say primarily orthopedic. Of course, that's what we're known for at
Yeah.
Howard Head. But if anyone came in that it was more of like a one-off, I would say.
Okay.
Not as common to have other complaints.
What about altitude sickness?
Oh, yep. There's a lot of people that come in with that. So yeah, I guess outside of what I'm consulted on, we have a lot of just a lot of people who are just generally. So we had a lot of viral infections
Hmm.
this winter, and then of course that's exacerbated by altitude. So um,
Got it.
people coming from sea level, lots of hypoxia. We have some people come in with HAPE, which is the um, pulmonary edema that's associated with higher altitude. We have a lot of kids that come in too. So I know at UCH it's primarily adults because children's is right next door. But we do have a lot of kids that come in. And so that's also been a shift for me is just like, how do you work
Sure.
with kids? And, what types of things are they coming in for? And then I think the other thing is we do have level 1, level 2 traumas. So we do have, because I-70 is right next to Vale, we get truck accidents, car
Oh,
accidents,
sure.
um, and then medical alerts. So, you know, cardiac arrest in the county, stroke alerts, kind of you know, all the things you would expect in any other ED, just in a different, proportionally the population is smaller, but the influx changes dramatically in the winter.
Well, definitely like an interesting variety of being like an urban or a rural generalist
Yep.
and an orthopedic specialist.
Yes.
That's very cool. That's very cool. So tell me, what have you noticed the most that patients want when they come in to see you?
They want to know what happened.
Yeah.
Yeah. So they a lot of it's, I didn't even know that you can hurt yourself skiing. So that's a conversation that we have. Um, you know,
Really?
oh yeah. I think a lot of it is risk perception of like, you're on vacation. You don't expect to be in the hospital.
Okay, that's valid.
Yeah, and people are like you said are coming from all over the world. So we have people all over the US. Um, we have a lot of people in Europe, Australia because it's their summer, so they come here in the winter to ski. We have a lot of people from Mexico that are also coming. And so I think people's risk perception of what skiing is, what that vacation's meant to be, and when something like this happens, how that affects the course of their
Mm,
travel. Um, and so I will say that just knowing what happened to them, what this means for them, what they can expect next. A lot of it's also, why can't I get an MRI today?
Mm.
Questions like that. And then also just reassuring them that, hey, this isn't ideal. Of course, I wish I could tell you today exactly what happened, but especially with our soft tissue injuries and with, some people experience ACL tears very differently as far as pain. So, can I even get a good knee exam today? Are they guarding? If the doctor already did it, is it worth it for me to do it again?
Yeah.
And then being also having to say, like, sometimes we just don't know. Like, we can tell you what may have happened, but being really honest with them of hope for the best, expect the worst moving forward, and let me tell you exactly what you need to do next, because right now your brain is very overwhelmed by this whole experience. So let me help you.
So what I'm hearing is people want to know what's wrong. They need some
Oh yeah,
reassurance and
yeah,
they need to know what to do next.
yeah.
Perfect. I think that makes a lot of sense in any emergency department. That's,
Hmm.
I feel like, what people want the
Yeah,
most, but that makes sense, especially if you're on vacation and you're supposed to be having a good time
yeah.
and you want to know what happened and maybe you ran into a tree and hit your head. That all seems very valid.
Yeah, and also it's like, can I go to dinner with my family tonight? We have reservations. Can I even leave the hotel room? And so just also encouraging, like, yes, I want you to participate in your daily life even though that this happened. These are all the things that you need to do to help manage your injury, but please continue to live your life
I love
as
that.
best you can.
Kind of stop that fear avoidance right away.
Yeah, especially like, I mean, and I think part of it is anecdotal coming from my experience of not wanting to sit life out just because you hurt your knee.
Yeah.
Um, yeah, you got to keep moving forward, and nothing's going to happen that same day. You're not going to get surgery that day. You're not going, you know, there's a lot that you just won't get to know for a little while, so you might as well keep living.
And be patient. That must be really
Hmm.
frustrating for people.
Oh
So
yeah.
what have you learned about like how to streamline the referral process and how to collaborate with other providers? Because it
Hmm.
seems like if you have 700 patients coming in with these types of injuries, this has
Yeah.
got to be a well-oiled machine by this point.
Yes.
So explain that. Like how can people best like set up that collaborative model so that they can really get these patients through quickly and
Hmm.
easily if they're trying to start a similar program?
Yeah, so I think a lot of it is just having the physicians know how we can assist them,
Mm,
because depending on the time of day, there might be one physician, or during the busy time, there's three in the emergency room, but they're managing everybody, and so we can help with the throughput of, you know, more or less the clogging of the emergency room, where it's like all of these people are coming in with orthopedic injuries, which is clogging space for people that might have a higher acuity.
yeah.
And so being able to say, hey, the x ray came back negative. I'm going to go see this person and see what I think is going on and start that education process so that by the time you see them, a lot's already been done. But of course, that also means that you have to build a relationship with them and they need to be able to trust you,
Hmm.
um, because they're used to doing more of that heavy work of diagnosing patients and doing all the education and getting them out. And so being able to say, let me help you with some of that. And I will let you know if something comes up. So sometimes it's like, hey, I wasn't able to bend their knee past 30 degrees. And the x-ray was negative, but I'm a little bit worried about that. Do we need to, what do we need to figure out in order? Do we need more imaging? Could it be a tibial plateau fracture that we missed on x-ray? Or could it be a bucket handle tear, which, really just requires more of that. Please go to see an orthopedic doctor tomorrow so that they can hopefully do surgery in the next few days. So a lot of it is just figuring out who who is your patient at what time. How
Hmm.
can you really help get people out, while also addressing their care? And I think that, I mean, we kind of had it down to it, like you said, it felt like a science at some point where people come in, they get triaged by nursing, imaging gets ordered, the imaging techs either come in or take the patient, and it's all close to each other because it's such a small hospital. So then they get the imaging, the doctor typically would come in, see the patient, examine them, and then consult me. But if that part of the process was a little off just because of how busy it was, I would try and talk to the physician and say, hey, I this is the results of this. I'm going to go see them, start that process. And then by the time the doctor can see them, usually we can get them out the door, I want to say within 2 hours. So we had it down. And I think a lot of it too is just getting used to, like, all right, if someone comes in with this type of injury, this is my spiel. And let me really hone in on that so that I can do it in a very timely and efficient manner.
I love that. And then I'm assuming there's also processes for escalation when things are not going the way that they should.
Right. Yeah. I mean, sometimes people come in not in a lot of pain, and turns out they have a femur fracture, or like they're just things happen and you're like, okay, this patient is no longer for me right now. Let's get other people involved. But typically, most of the time that didn't happen. It just sometimes did.
Every once in a while, you got to be prepared, right?
Yeah.
Because there's still could be an emergency happening.
Oh, always. Yeah. Especially based on where people are coming from, if they're coming from sea level, or just, sometimes the person that's visiting them faints because they got they got a little
That's happened
disturbed.
to me.
Yeah.
I actually had a patient's family member code while I was working with the patient. So that was a first for me, but it does happen, and you have to be prepared, like any emergency PT. All right. Well, this has been really helpful information. So I think last thing I want to ask you, and then I'll let you share any of your like parting thoughts, but like all I'm thinking about right now is like, what kind of stuff do you need to have? Because I know I don't use a lot of stuff, but if you're bracing, wrapping, like booting, like tell me, like, what are the like top 5 things that somebody needs to have supply wise to be able to do what you do?
Yeah. So lots of braces, mostly hinge knee braces. So we have 3 different kinds. There's what we call our economy brace, which provides lateral support, but is kind of a basic neoprene brace, more for MCL injuries. We have a recovery brace, which is the next level up, that has the locking and unlocking mechanism, and you can set degrees of flexion and extension with that. Still neoprene, very user-friendly, kind of like your go-to ACL tear brace. Provides a lot of stability, but isn't the T-scope brace, which is our post-op brace that a lot of our surgeons use up here. So I'm thinking more tibial plateau fractures will be in that one. Or just someone with a very unstable knee. So they could have ACL, MCL, meniscus tear, sometimes PCL. So we're putting them in that one. And it kind of looks like a robot arm, but it extends so that the lever arm is longer. So lots of bracing, crutches galore, and of all sizes. So youth crutches, regular crutches, tall crutches, and the ones that you don't have to screw. So I would say like, do not get those if you have a say over your inventory or your supplies. Get the ones that have the little red tabs that pop out, and then you can easily shift the handle. So
that sounds amazing.
Yeah, like honestly, that has saved so much time. Like whenever I have to do one of the crutches where you actually have to like unscrew the mechanism, it drives me nuts. Because it takes like 5 extra minutes, it feels like, to do that. And then walkers, because sometimes we have people with pelvic fractures, or just older folks who are still skiing and crushing it. But balance wise, it's like we have a lot of people over 70 who are just skiing over 70 days a season.
That's awesome.
So just anyone who needs more stability with balance. I use Leukotape and coverall tape for AC joint separations. So a lot of slings as well. And then heel lifts for our calf strains. So being able to put a heel lift in someone's shoe usually really helps facilitate a normal gait pattern.
I love
that. So I would say those are primarily what I use regularly, just orthopedically. Yeah.
I love that. Okay, so final thoughts for people who are like practicing maybe in a ski
Yeah.
resort, maybe in a rural emergency department. Like, what are your best words of advice for somebody who's trying to get into that or is doing that?
Yeah. Um, get as much support as you can. So
Mm,
I feel very lucky that this position was well established prior to me being here, and is heavily supported by the emergency department as well as Howard Head Sports Med. So
yeah.
Howard Head, they provide the inpatient and outpatient services, and they have multiple clinics all across Summit County, Eagle County, and now also Pitkin County, which is near Aspen. And so I think having their support, knowing, hey, like, you're saving us a lot of like PT resource time because we have someone there full time, and you're able to make these referrals, and the emergency department loves having you there because you're helping get people out, and you're taking ownership of this patient population that really is ours. And
Mhm.
so just knowing that across the board, people supported me. I think that was really critical. And then also, always looking for who are we missing? Like, what type of people
Yes.
aren't we capturing? So I did do a presentation with the physicians on how they can utilize our services better, or when, when in this situation, lean on us for this. And so being able to support the physicians, especially when they do get slammed with so many patients. I mean, it's a 20-bed ED, but sometimes we would have 10 people out in the waiting room. We'd have people lined up in the hallway and on gurney beds. So whatever we can do to support them, and being able to also get people just better care with outpatient. So saying, "Hey, you had a head injury. I have at least 2 PTs downstairs that see people right after concussion, and they can help you return to sport. They can help you return to work. They can help manage your symptoms. Like, please go see them within 48 hours." Research shows that they do better when you go to see a PT within that amount of time, which I think, being at university, we both know it's really hard to get people in right away. And
Hmm.
so I will say any type of streamlining you can do or facilitation, um, really try and capitalize on that because it really does affect patient outcomes and their satisfaction with their care.
I love it. That is
Yeah.
makes a huge difference. I'm sure your
Hmm.
patients really appreciate that. Well, thank you so much for being with us
Yeah.
today. You've been in the ED now and you're officially discharged.
Well, thank you for having me.
Thank you so much. Thank you for listening. In the ED Now is a podcast hosted and produced by Rebecca Griffith, the ED DPT, as part of Rebecca Griffith Physical Therapy LLC. Our podcast makes you an excellent emergency department physical therapist. This podcast is intended for educational use only and is not intended as clinical or medical advice. While we make every effort for accuracy, factual errors may be present. Since you've been in the ED, I'm prepared to give you your discharge instructions. Please subscribe, share, and find more at the eddpt.com. You're officially discharged. Thank you for listening.